Thank you all for the opportunity to present today. My name is Ann Miller. I'm the Executive Director of Project N95. I want to say a special thank you to Helpful Engineering, Open Source Medical Supply, and Field Ready for organizing this symposium. I really appreciate that opportunity. Let's see if I can find one of the 500 screens that I have open here. One second now. Let's just do it this way. At the beginning here. So one more. Let's try again. Okay. Share. For those of you whom I've not met, which I think is most of you, I am the Executive Director of Project N95. I joined the project on the third day. We were born in the COVID crisis. I come out of the medical device industry, commercializing new medical technologies for various different large manufacturers, many of whom you would recognize. Project N95 came together to say, how can we help? We were really focused on getting PPE to frontline healthcare workers. And we have over the many months now developed key partnerships with Andy Slavitt's United States of Care, VTEX and UPS, who are our commercial partners, get us PPE. And we also work with a large number of medical associations, some of whom are listed here. Our real mission is to get quality PPE to healthcare and essential workers. And over time, we've come to understand that what an essential worker is more than just those that are the big E essential workers, but all those for whom work is essential. If you need to get food on your table, you also need PPE, not necessarily healthcare grade PPE, but you need to have quality PPE that can protect you and keep your family safe. So we are very focused on providing equitable access of quality vetted PPE as quickly as possible. We see the world as being in three parts, even though I did this in a 4-square. So there are the people who have money and access. These are your very large hospital systems. They have secured their PPE through contracts with Prestige Ameritech and other major suppliers overseas, and they have what they need. But there is a large number of people who have resources yet lack access, or have no resources or not sufficient resources and lack access. So we're really focused on this left-hand side of the table, of this table. So people who don't have access. And what are the primary reasons why people don't have access besides not having money? Suppliers are out of stock on a more permanent basis. The supplier allocates based on what you bought last year, and you hardly used any PPE last year, so your allocation is very small this year. Because of the demand, the minimum order quantities are high, so people can't participate in this marketplace. You've never before purchased PPE, you don't really understand what you need, or you have geographic barriers to participating. So we know that getting PPE to Alaska, Puerto Rico, and Hawaii is very expensive. You live in a rural community in South Dakota, it's hard to get PPE to you. So we are working on all these different aspects of access. So lack of access due to money or lack of access due to other barriers. And these are the people that we're trying to serve. So just for context, I mean, even though there's big hospital systems, there's 230,000 independent medical practices. There's another 200,000 dentists who need PPE. And then for people who lack the resources and the access, we're talking about tribal populations, free medical clinics, other groups in that category. So this is not any surprise to most of you. That demand shock scramble that set everything off in late March, this really brought forth to me. You could really see you had all these new unvetted suppliers coming in, some of whom were trying to be helpful, some of them had connections that they repurposed in China, and some of whom were pure speculators. And we saw that a lot in late March and April, and then it kind of settled down. And now again, my LinkedIn is like being peppered with people who have bought large quantities, are housing them in warehouses, and are speculating to make that arbitrage opportunity. So we saw that there was a problem here that needed to be solved, right? How do you know what is a quality product in the context of a high flux regulatory environment? There's so many different emergency use authorizations, enforcement policies, and then the standard F510K guidances that clearances. So there was a lot of things that made it opaque and hard to know whether or not you were buying a quality product. So how we serve, remembering that we're a 501c3 charitable organization, and we're not here to profit from the pandemic, how we serve is one, to identify supply and demand. So we have people who come to us needing product, and we have people who come to us offering supply. We vet these suppliers. We make sure that we have rigorous due diligence. We make sure the product meets the standards for the US marketplace, and that the supplier themselves is a reputable supplier. We're not really interested in getting supply from somebody who's speculated and has a warehouse full in Charlotte, because these people are not in it for the long term. And we believe that we should be that trusted source of supply, that we know that people are dealing with a pandemic and they have other problems than to worry about, will the supplier be there next month? So we use Moody's and other databases to make sure that that supplier doesn't have criminal charges against them or have sanctions from HHS or other reasons. So we both identify the supply and demand, we vet the products from the supplier, and then we offer two different ways for people to get product from us. They can come to us in a marketplace format. They can just come in and buy what they need, check out, and take it and get it 5 days later. It's not quite as fast as Amazon. And then the other thing we do is that we know that people don't have access because the MOQ is so high. So what we do is we go out to organizations, and if you know an organization who needs PPE, we would gladly do this for your organization. We say to all the members of the organization, we let the organization decide what PPE they're interested in. They make the choice. I believe in like try before you buy, know before you go, like don't feel like you're getting something that is not going to serve your needs. So we take that, all the members come in, they order the quantity that they want. And then we roll that big order up and we negotiate the price with the supplier, and we ship it to UPS warehouse, and UPS does the last mile pick and pack. So I just want to mention to you, coming out of the medical device industry, I helped stand up this rigorous vetting process. It's really important to me that our customers understand that we have gone through it with a fine-tooth comb. And I will give you two examples of situations. Very often people will say that they have an isolation gown, and then the isolation gown, you ask them if it, what AAMI level is it tested to? And they'll say, well, the fabric was tested to a level 3 standard. But that is not how we judge the quality of an isolation gown. An isolation gown is based on the finished product. So what is the tensile strength of the seams? So these are the things that we're really looking for in a lot of detail. We've had customers come to us and say, we don't want to buy this surgical mask because it doesn't have an FDA logo on it. And we tell them we routinely disallow product that has an FDA logo on it because that product is non-compliant. You cannot bear the FDA logo on a product in the US. So we do have a very rigorous process. We have playbooks for every single category. One of the playbooks that we have is for the ethical supply chain, to identify people, organizations with unfair labor practices like Uyghur labor and things like that, and gloves. There's been issues in the glove industry also about labor practices. So we use outside counsel. We have very fortunate to have Ropes and Gray advise us on all FDA matters. And so we take our vetting really seriously. So since we started counting in May 15th, we have delivered well more than 2 million units of PPE. We have served frontline workers and over 20,000 people who come to us to buy. Remembering that we're not here to sell PPE like Amazon. We charge the 2% fee to suppliers and the 3% fee to cover credit card processing. So the organizations that we serve are wide and disparate, and we really are focused on serving the underserved populations. So I wanted to give you an example. So a group led by the American College of Physicians came to us. There was 14 different, 16 total medical societies. They came together as a group to try to get the best possible price that we could. So the AAFP Foundation with their free clinics and 14 other medical societies got together. We asked them to estimate their volume, and then we have our own estimating methodology because we found that People aren't that good a judge of what they need. And so we offer people the opportunity to buy at really small quantities if that's what we need. So out of that one aggregation, we delivered more than 727,000 units of N95 respirators, face shields, and isolation gowns across all 50 states. And then just this week, nothing to do with this group order, but I tacked it on here. We delivered 100,000 surgical masks to a South Dakota tribal community. We delivered 420 N95 respirators to a clinic in Harlem. We're really, with that margin that we make, that 2% that we use to fund our operations, we've been very fortunate to have people donate a tech stack to us. So we're really looking to be able to use our margin to deliver the mission. So there was a question that had been asked at the start of the symposium when the organizers at the beginning about how we forecast demand or the use of burn rate calculators. And I put this up here just because it's a really interesting phenomenon to me that the primary care practices don't seem to be using burn rate calculators per se. They have surveyed their members. They know like what individual practices have an idea. Some groups are more sophisticated in their forecasting than others. So what we see, some clinics who buy from us, we have a subscription basis. They come back over and over again to get the PPE they need. So they're using burn rate calculators, but as a general rule, the dentists and the doctors, independent practice, are not using burn rate calculators. But what we see is that I find it really surprising that the average number of products purchased in an aggregation was 3 boxes of N95 respirators in the small and the medium large. And this is, 3 boxes is 60 N95s. It doesn't really last you that long if you're using them on a per patient basis. So clearly they're not doing that. So face shields, they order average number of boxes is 5. There's 10 face shields in a box in a package. So they're getting 50 face shields, and they're ordering 11 packages of isolation gowns. These were level 1 isolation gowns in this. So that's over 150 isolation gowns. But what we also see, so I don't from my perspective, it doesn't make sense to order such a small quantity, except for you're able to come back and buy from us, which is true. You don't have a lot of capital to spend because product is extraordinarily expensive now. So the other thing that we see is that the demographics of purchasers has shifted and the supply chain hasn't fully adjusted. And by that, I mean that we see a lot more demand for smaller sizes, and those are more difficult to get and often more expensive. So I just wanted to say in summary, our current state of affairs, we see still a very urgent need for PPE. We're starting another group order. We just finished one. We're starting another one on Monday. The number 1 requested item is nitrile gloves, N95 respirators, isolation gowns. You can read the list here. And we see PPE needs from community-based physicians, dentists, community clinics, rural institutions. There really isn't any, I would say that since my joining the project on the 2nd or 3rd day, I have seen no diminution in the demand for PPE. It has only continued to go up. And the nitrile glove demand probably 6 weeks ago really started to pick up, and it was clear that we were going to have a problem with gloves. The solutions in my mind are, that slide's very wide. There's a supply, demand, and distribution are part of it, and then there's buyer education. And I think that for sure we have a need for U.S. government leadership and a coordinated federal response. And I know that there's a project N95 in the Netherlands that vets suppliers, and then the Dutch government purchases from that organization. And there should be a way for not just the 3 major manufacturers or the 5 major manufacturers, but all of the people who are working, who have quality PPE, should have an opportunity to participate in the market and have and in that coordinated federal response. I do believe that ultimately our best interest as in the U.S. is in a coordinated global policy rather than just a U.S.-centered policy. We see that a lot of the money has been going to bigger firms. And I know that there are many smaller firms who are working, and I would love to see us get a better domestic supply of the spun bond product. There's very limited capacity in spun bond materials, and it costs money to set that machinery up. And then I think it would be really important for us to have national demand forecasting. What we see is that in segments that have had low barriers to entry, like face shield manufacturing, we have many new entrants, and now they're in an uneconomic prospect, right? So we need to be able to identify where we have need and make sure that we're supporting entities in that level and dissuading people from entering into marketplaces where the opportunity to have a commercially viable operation is limited. One of the things that's really important to me is that we need to expand buyer education. And I think there's a whole lot of public health messaging that needs to be done for the general public, but among healthcare buyers who are not typical PPE workers. So we're not talking about the ER docs or people in hospitals, but people in primary care practice. People need to understand the trade-offs about the level of prevalence in their geography, in their town, and what is the COVID prevalence in their practice setting, what is your personal risk profile, and what are your financial resources? Because we see people buying a surgical N95 respirator, which is the most expensive product other than an N99, but it's an expensive product, and you're working in a primary care setting with very low COVID, and you don't necessarily need to buy that product. And by buying a standard NIOSH respirator, you free up more of that supply for surgical applications or high aerosol applications. So I think that we need to do a lot more educating around the higher product like armamentarium and the hierarchy of use. The other thing that's one of my pet peeves is fit. It really matters how a product fits, and if it doesn't fit well, it's really not conferring the benefit that you think it is. We have a portable fit testing unit that we can lend out to people to verify fit if they're not certain. And then the other thing that I talk about is the MPF, right? You know what your sunscreen benefit confers if you're a 50 SPF, you know your UPF clothing, and we need to have a mass protective factor so that if you're a teacher, that you know that your mask is conferring some benefit, that not to say that, a bandana around your face is better than nothing, but if you're spending money on your product, you should know that that product is conferring the safety that you think it is. So this is more of who we are. We are a 100 plus member team, all volunteer led. And what I was going to say is we are here to help. We were born in that with that idea. How can we help? And that's really what Project N95 is all about. We're a nonprofit here to help. So thank you very much. And I appreciate the opportunity again.
And that was wonderful. There's a couple of questions. One question from Darin Lewis was, does Project N95 identify supply and demand limited to PPE, or do you cover ventilators and other devices as well?
Yes, when we cover ventilators, I actually personally vetted all the ventilators that we had earlier on. We've seen reduced demand for ventilators, but I'd be happy to work with anybody on vents. I've also vetted all the in vitro diagnostics that we have in our marketplace, and I'd be happy to work with anybody on IVDs. It's really, we talk about PPE, but it's really all of the critical medical supplies that you need to be safe or to deliver healthcare in the context of the COVID public health emergency.
Fabulous. I can't thank you enough. And Robert is asking about demand for PAR.
Pappers. Yeah, Pappers.
Yes.
Yeah, that's something I just actually wrote it down yesterday. Pappers come up and then they go away. There's a very specialized need for that, but I'm not sure that we have good representation of Pappers. I'd love to follow up with you. You can track me down. I'd be glad to talk about it.
Robert was asking, do you charge for your products, which you do, as I understand.
Right. So yeah, that's correct. In our marketplace, we sell at that we charge the supplier a 2% fee, and we assess a 5% fee on 5% total fee. It's split between the supplier charge and the credit card processing, but we're really not here. We're not here to profit from the pandemic. That's just not what we're about.
Warren is asking about...
I am just going to stop on the Q&A for 1 second. If we can keep that until after all of the speakers, that would be wonderful. So let's go ahead and go to the next presenter.
So this would be, why don't we go back to Darin? If you were able to sort your slides out.
Let's try this one more time. I hope it's successful. Oh my gosh. I think so. Does everyone see that?
Yes, that looks like it's great. Thank you.
Great. Thank you so much. Thanks again. Apologies for the delay. Thank you for the invitation. My name is Darin Zehrung. I'm the Global Program Leader for Medical Devices and Health Technologies at PATH. And I'm also joined by my colleague, Pat Lennon, who is a program advisor and leads our supply systems and equipment team within my program. And he'll be able to answer questions as well. Later in my presentation, I have some elements that he can also weigh in on in terms of our work. I thought I just would cover a high-level snapshot of what we're doing in supply chain, different supply chain efforts, some with a COVID-19 theme to them. And so, so if you're not familiar with PATH, PATH is a global team of innovators, and we work to eliminate health inequities so people, communities, and economies can thrive. And we use cutting-edge research to tackle the toughest global health problems. Our headquarters is in Seattle, Washington, and that's where I'm based, as well as Pat. But we have truly a global presence, global team of over 1,500 employees working in over 70 countries, mostly in Asia and Africa. And we specialize in designing, developing, and scaling solutions in 5 core areas: vaccines, drugs, diagnostics, devices, and health systems. And our global team of experts, scientists, health professionals, business leaders, engineers, advocates, and experts from dozens of other specialties are largely from the places where we work. And that's a big area of focus for us is building country capacity and really that support and elevating the global south is key to our mission. Our work improves the health of hundreds of millions of people. PATH has been around for 40 plus years. I've been at PATH 22 years, and actually Pat his tenure precedes mine in terms of his time at PATH. So there's a lot of folks at our organization that spent much of their careers dedicated to PATH's mission. The Medical Devices and Health Technologies program that I lead, we offer human-centered design end-to-end throughout all phases, elements of the value chain, complementary support, and partnership is key to our success and in our mission. We have multiple disciplines within our program, and we have teams that are focused on particular technology areas. And so Pat represents supply systems and equipment. We have other pharma-related teams, packaging and delivery, formulation, but also a broader team focused on a number of health technologies and medical devices for reproductive health, neonatal health, et cetera. We work to try to accelerate, products through the value chain, through the valleys of death. We see, there's the upstream valley of death where technology can, be filtered out and not, be successful, and then later downstream in terms of programmatic introduction and use. And so there's been examples where technologies that maybe were before their time, where they're just now realizing their promise. And the Kaya diaphragm is one in particular that you'll see on the next slide. We work to assess, technology. We have 2 teams under our Living Labs project, one in Kenya, one in Zambia, that's focused on rapid human-centered design, evaluation of innovation, be it a practice, be it a innovative technology, with cycles of weeks in terms of the rapid turnaround. And that's a capacity that we're working to apply to other areas as well. And of course, we're focused on strengthening innovation ecosystems. So these are some examples of products that we've been involved with over the years that have made their way into programmatic use. Some of the greatest hits, so to speak, in terms of like the vaccine vial monitor or the solo shot, Uniject, auto-disable syringe, or the solo shot syringe, it's auto-disable, as well as the Uniject, which is an auto-disable prefill injection system. You see the Kaya diaphragm, and then other technologies that we've been involved with. And this is a way we can track our progress and the impact that we're having on our mission and overall global public health. There was an earlier question on oxygen, and so I thought I'd briefly cover this. We have a new Bill and Melinda Gates funded project focused on oxygen access and respiratory care. We've been working for a number of years in this area to try to understand the challenges, the value technology or innovation might bring, advocating for expanded use. We work to expand the use case for oxygen and the essential medicines list, for example, with WHO, and then working to convene different stakeholders. And we have a respiratory care response coordination that we've been leading under this project. It involves working with CHI and the Every Breath Counts Coalition. And its goal is to support countries in planning and executing a respiratory care plan to meet the demands of COVID-19. And you can see there we have a sub-goal focused on improving access to oxygen therapy and other essential equipment. And this is actually a really rapid front-loaded project that the team has been working on and expanding into a number of different countries. The other project I wanted to mention is the Access and Delivery Partnership, which involves working with UNDP and WHO and the special program for research and training in tropical diseases. And it's focused on the value chain for technology in terms of new technology, regulatory approval, prioritization, procurement, distribution, storage, and then ultimately service delivery for patients to achieve public health impact. And if you have questions about that project, please let me know. We've been also working to support CEPI, the Coalition of Epidemic Preparedness and Innovations, as well as Bill and Melinda Gates Foundation on the response to COVID as it relates to vaccines that are in development. So early on in the pandemic, we worked to identify if there were challenges in terms of the drug substance supply chain or the drug product supply chain, as well as the overall immunization supply chain and the delivery of vaccines into programmatic use. And some of the vaccines require an ultra cold chain, -70 C. And so that represents additional logistical challenges that Pat and his team have been working to address and evaluating a number, dozens, over 100 different scenarios for cold chain, as well as total cost of delivery analysis for the foundation, for CEPI and other stakeholders. And then we have also been working to, as I mentioned, on looking at the drug product side, to the packaging and delivery technology assessment, availability of glass vials, septums, what are the supply gaps and challenges, looking at alternative technologies such as blow-fill seal for presentation and delivery of a vaccine, looking at alternative presentations vaccine, a pouch technology which could hold maybe hundreds of doses, and looking at a number of different variables: technology readiness, market availability, compatibility with the different vaccines, the human-centered design focused in terms of usability and acceptability, safety, wastage, cold chain impact, as well as also total cost of delivery. So we continue to have these sprints with the Bill and Melinda Gates Foundation, as well as CEPI, to answer a number of different questions and to inform decision-making. The work that we've done has informed the secure securing supply for glass vials, et cetera, that CEPI and the foundation have done in support of their respective grantees for COVID-19 vaccine development. We recently completed a global assessment of syringes, auto-disable, reuse prevention, in terms of global access, and if there are any issues related to having sufficient syringes to deliver the billions of doses that is anticipated for introduction into immunization programs. I'll stop there. Hopefully that was helpful. Pat, please weigh in if you have other comments. And yep, over to you.
Nothing else to add for me right now. We'll wait for questions.
Thanks, Pat.
All right, well, now that I've been scolded, we'll hold questions to the end. Grace Kramer from the UK Foreign Commonwealth and Development Office, are you here and ready?
There has actually been a schedule change on that, so we are going to have James Ford from the NEAD coming in next. James, are you prepared? Awesome.
Yes, I'm here, Devon. Shall I take it away?
That sounds brilliant. Thank you so much.
Good stuff. Good day, everybody. Thank you very much for your time. I'm just going to get the screen share operating. I think I'm sharing the wrong one, which is not what we want. Bear with me, I do apologize. Let's try that. There we go. Okay, I'm hoping everybody can see my screen okay. If we could get a nod from you, Devon, that would probably be sufficient.
Yes, you're set. Thank you.
Okay, well, look, thank you for your time, everybody. What we're going to walk through today is the National Equipment Appeal Database, which was a database which underpins several different PPE identification and placement initiatives that took place right at the beginning of the COVID-19 outbreak in the UK. Just a quick introduction and a picture. I know I haven't got a photo anywhere else. So I'm James Ford. My day-to-day expertise is in database design and deployment and also digital marketing. I run a business. I'm also the leader of a business where we develop databases quite quickly for everyday business use. And it was a skill that came in particularly helpful when we were at the beginning of the pandemic. I just wanted to say a special thank you at the top of the presentation today to some of the leaders of the various charities and initiatives that we helped underpin. Dr. Dominic Pimenta is one of the members of Heroes, but really the founder, and did an incredible job. Paul Ford was the chairman of SHIELD. Nigel Daly from Helpful Engineering was incredibly important in helping us move the campaign from locating surplus PPE into more of a creating our own sustainable PPE solutions, which could actually be used in emergency care settings. Maxine Chan and Michelle Dawson were another two individuals who were absolutely pivotal to the success of what we rolled out and what is still rolling out today. So how it started, when we sort of jump back to the 20th of March of this year, when things really started to take grip in the United Kingdom, Paul Ford, who does so happen to be my father, he's a really shy guy, and you can see from this photo here, he looks a bit like a cat in headlights. He's not a natural in front of the camera. He took to LinkedIn and recorded a short video. He runs a construction business. He said, look, we have to close our sites. If we need to, if there are individuals out there that need PPE, you can use our surplus supplies. This video reached around 35,000 views in a matter of days. And the thread of comments was as long as my arm, of people saying, I have surplus PPE, here, take it, please find a home for it, Paul. And a number of individuals, whether they were frontline care workers or they were individuals that were working in care homes, funeral directors, all of those vital job roles that still needed to take place were searching for their own PPE because the supply in the UK had more or less disappeared. In order to make it work, and from that, contractors' appeal was set up as a campaign which reached out and communicated directly to the construction industry. In order for that to work, we needed to create a solution which could capture all of the donations, but also capture the need as well, and then ultimately perform a matching process so we could get the PPE into the hands of those that needed it most. When we started to come to market, we realized there was a number of others who had similar ideas and were setting up their own campaigns. And so Donate Your PPE, which focused on the furniture industry, Heroes, which was very much centered around the NHS and actually communicating directly with those frontline care workers and the individuals that were in the most desperate need for PPE. Med Supply Drive, again, this was an initiative and an incredible charity which came out of Imperial College London. Some of their senior students putting that together, and it's still performing incredibly well right now, and Do Some Good in the real estate industry. In order to keep all of this connected and communicating clearly and working together, an overarching charity was set up called SHIELD. But what underpinned all of these charities was the NEAD, the National Equipment Appeal Database. So how did we locate PPE? Well, we got behind campaigns which were speaking directly to industries where surplus volumes or surplus PPE existed. They could speak directly to construction, speak directly to furniture. Also, we supported some campaigns that were speaking into the pharmaceutical industry, where nobody were at the offices or in their normal places of work, but there were storerooms full of PPE which could be put to good use. We use social media and celebrity endorsements to gain a viral element to the campaign. And when somebody had any sort of donation, they would come to an online form on any one of the campaign sites, and they would make the donation of the goods that they had. On the other side of that, how do we identify the need? Well, Heroes and Med Supply Drive were two of the campaigns which were the most important. They were really the engines behind letting everybody that was operating on the front line or was an essential worker, that there was a PPE option for them, something that could help them, make them feel safer and be safer in their place of work. The most important aspect here of making sure that we could identify need was communicating and connecting with micro-influencers, making sure that our message was tidy, people knew where to go to get help in a matter of a few simple steps. But those union leaders and community spokespeople who probably wouldn't view themselves as influencers very quickly became the essential communication route that we needed to take in order for notifying people that we existed and we had PPE that we wanted to place into the hands of people that needed it. And here, this is a pyramid, and really we were operating right at the pointed end. We weren't looking to speak to procurement offices. We were looking to speak to the individuals that were working on the front line that felt they didn't have adequate PPE, or they needed PPE because they were going to run out in the coming days. And by keeping the communications there, we could create quite an efficient workflow, moving the goods into the hands of the people that needed it most, rather than relying on small procurement teams that didn't have full visibility throughout the facilities which they were in charge of. And so to just help demonstrate how this process worked, I'm going to switch over to a short live demo of the forms and the app and how we did the matching process. So please do be patient with me. There's every chance that the live demo is going to go wrong in some way or another. But this here is a good example of what the donation form was. Now, in order for us to manage the data and make it work in an efficient manner, we needed good data control. We needed good data quality. And so whilst we gave the freedom to enter individuals' own personal details in, we put some quite tight controls around the items that they were able to donate. So what category did it fall into? What subcategory was it then? And if it was applicable, what was the size? Were they able to deliver? On the flip side of this, we kept the same controls with the same parameters on the items that somebody could request. And a key field on this side of the equation, this is the request form, is this individual able to collect it? And this was the logistics solution that we put in place right at the beginning of the campaign. And I'll talk a bit more to that in just a moment. A donation form and a request form then existed on every single one of the various different campaign websites, which NEAD was underpinning. And every single time a form was submitted, the data would flow into the NEAD database. And this is the application itself. What we did is we broke the data out into the donors, the donations, the recipients, and then the requests. So we would enter in a donor into the database, and then once we had the donor in there, we would then log their donations. What this allowed us to do was ultimately allocate the various different items which they had donated to various different parties. All of the goods that somebody donated didn't have to go all to one direction. We could use the 150 gloves for X recipient, but then the 50 or the 5 sets of eye protection could go to Y. This database is fully cloud-based, fully secure, fully compliant, running on Microsoft technology. And because of that, we then built our dashboards that went effectively to our matching team in Microsoft Power BI. Now, right at the top, as I've already mentioned, of the campaign, and really for probably the first eight weeks or so, we were running, maybe 6 to 8 weeks, we were running on a peer-to-peer matching strategy. And so here we can see all of the various categories that we hold, and we can drill down into the subcategories of goods. But maps would populate based on where we had items available of PPE. These circles, as we hover over them, will show us the quantity. The size of the circles would get larger if there was a larger quantity of goods. If I was to click on any one of these circles, it would load the information of that donor, so we could make a call and see if they were able to conduct a delivery or whatever was required. On the flip side of that, we then had the request data, which presented itself in the same way. As the circles got bigger, it was bigger volumes that were being asked for. And if I was to click on this, it would load the information just here at the bottom of the screen based on what the contact details were, so we could organize a delivery or a pickup. As it evolved, what we found was there was a lot of donations of PPE which were of small size and small volume. And because of that, some of the donations weren't being used. If somebody out of the goodness of their heart wanted to donate 3 sets of goggles or 3 masks, well, the need was always much bigger than that. And so to organize a pickup or a drop off, it seemed like it wasn't the most efficient use of anybody's time, and all of a sudden the donation went missing. So what we moved to after that 6-week period was working with some national carriers. DHL, in the case of the donations, would go and collect a donation as soon as it would come in. That would come into a central distribution center where we would manage quality control and also stock of what we ultimately had in our stockpiles for all of the various categories that we kept. On the request side, we then had a team who simply worked from the stockpiles that we had on hand at that moment in time and answered the requests that were coming into the team. That allowed us to move it in a much more efficient way with a greater level of quality control as well. As I mentioned earlier, particularly in the case of Helpful Engineering and Nigel Daly, the donations eventually started to deplete. There wasn't, the economy started to get back to normal. People were going back to work, and therefore those that were donating said, actually, I need to keep some of this PPE for us to carry out our day-to-day jobs. And so Shield as a unit took the decision to start investing in sustainable PPE solutions, where 3D printed visors were taken all the way through to receive CE markings, which meant they were safe for use within various settings. And it was really Nigel Daly of Helpful Engineering that helped to make that a reality. And that's my 10 minutes for the day. And of course, any questions, I'll be happy to answer them.
Well, that was an amazing presentation. It was really interesting to see what happened there. We had followed along quite a lot of this, but that was definitely a different perspective to look into the, sort of the databases point of view. I know that you guys focus very much on PPE. Did you do anything with devices like respirators, CPAP machines, ventilators?
We didn't, James. No, we kept it purely PPE, focusing on really the primary categories that you would have seen in the presentation.
Yep. I was really interested in how did you manage your quality control?
It's a good question. So in the initial instance, we had to work, quite hard with some data protection and generally accountability lawyers to state that these items have been donated, and it is ultimately you that is accountable should you choose to use the PPE. Because of that, we naturally had a number of individuals and a number of the requesters inside the very controlled environments, working in hospitals, working in doctors' practices, saying, unfortunately, we're not going to be able to use these goods, and they would go and find solutions from elsewhere. Once we moved to the centralized stockpiles, we then had trained individuals who could actually check whether something was of adequate quality, of adequate CE marking to be placed into a stockpile, which would go out to those more controlled care settings. And anything that didn't meet those requirements would go into I don't want to use the word second rate, but it would be something that was more viable to go into a less controlled setting. And so we would make best of the stocks that we held onto.
That's quite interesting. I think it's very impressive what you guys got done. So well done. In terms of needs that you see today, do you have any analytics on what you're seeing now?
Interestingly, in the UK, and this compares quite, it's a strong contrast to what Anne was saying earlier on. In the UK, there is really surplus PPE in many circumstances. The market is now supplying PPE at cheaper than it ever has, and with availability from more places than it was before. And as a result, requests and donations, as far as the NEAD solution is confirmed, are almost running at zero in comparison to what they were earlier in the year.
Well, that's fabulous to hear. I mean, in many respects, obviously you guys put great work in, and I think you've answered the call. So that sounds amazing.
Yeah, it was unbelievable. Honestly, I've never had the experience of working with such a dedicated group of people who were working so many hours of the day to get it done. And we eventually moved in excess of, I think it was closer to 2 million items in the end, in a relatively short period of time. So it was incredible.
Have you looked to deploy your system in other
Do you just want to hold this
circumstances?
conversation a little bit longer? We do have some other questions in the Q&A.
Sure.
We've only got about 5 more minutes.
Go ahead,
so if you'd
Devin.
like to move to those. Okay. So the first question from Robert Reed is there a demand for PAPR as an alternative to N95 masks? Did we address that earlier as a group? I think that was just for Project N95. So I don't know if anyone else wants to weigh in on that, Darin or James.
Could you repeat the question, Devin?
Sorry, at not 900 miles an hour, is there a demand for PAPR as an alternative to N95 masks?
I have seen, we have had requests for PAPRs. I think demand is more that is an overstatement for what I've seen. It's definitely not like a high demand item, but it doesn't mean it's not wanted.
Perfect. And then Kevin Patel from Hermtech was asking, how do you suggest domestic manufacturers get melt-blown or spun-bound development if all of the machines are basically using proprietary tech developed in Asia and the US has lost the manufacturing knowledge?
Yeah, this is a tough nut to crack, no doubt about it. There are spun-bond manufacturers in the US, and certainly they stand to benefit the most by contracts that might be let by the federal government if they should decide to do that. But otherwise, I think, there certainly are NIOSH operations that are setting up in, I know there's one in Southern Ohio, there's one in New Jersey, there's people are using PPP funds to set that up. I know it's a capital intensive business, but I think it's a matter of connecting the dots to get it put together. I'd be happy to talk about it later. You can schedule time, we can talk on my calendar, be happy to try to help.
And then Darin,
I was just going to say, we have a domestic manufacturing program at Project N95 where we're trying to connect domestic manufacturers with the resources that they need in order to break into the market and be successful. So,
And it looks like we have a question from Andrew Lamb for Darin from PATH. Do your staff in the field around the world also work on need demand identification? Darin, if you'd like to go ahead and unmute to answer that, that would be wonderful. Right, I think we might be having a couple of additional tech difficulties there.
I'm sorry, I'm back.
Yep.
Can you hear me now?
Perfect. Yes, thank you.
So thanks, Andrew, and hello, Andrew. It's been a while since I've talked to you, but thanks for the question. And we demand is really key. Understanding both the need, but also market potential is something that we work to address early up front. The value proposition that a technology might represent. And that will inform not only sort of the global public health stakeholders and decisions that need to be made, but also the developer. You know, we feel it's our duty to try to have those honest conversations early on, even if they, you know, are a bit bring, you know, a developer down to earth, so to speak. And but that reality of what they may face, and to get through both valleys of death in terms of, you know, product development and program introduction is really key. So helping to educate the markets and low and middle income countries for those developers that don't have that understanding, and all of our staff globally are engaged in that manner. Hopefully that answers your question. Over.
Brilliant. And then are there any rough estimates on demand for BiPAP devices in addition to ventilators? Question for any of the panelists.
I just want to offer up that we've seen a lot less demand for ventilators now than we have at the beginning of the pandemic. And I think that is in part related to the fact that clinical practice has shifted and vents are being used less to support patients, and people are being intubated at a different stage of their disease. As someone who lost my mother my mother-in-law to COVID, and who had COVID myself, I don't diminish the need for BiPAP devices. And I just don't have any information that would enable me to make a forecast on that. But again, if you want to talk more about these devices and how we could help you, please let me know.
Perfect. And then one last question for James Ford. So many of us small PPE making and finding groups would really have been able to serve needs better if we had employed your data handling. We've used the online request and donation forms, but did not move to a streamlined setup to match available materials to the need. That part we did manually, along with hand matching in spreadsheets to control experience matters. It looks like there's less of a question there directly, unless there's anything to that anyone wants to speak to.
I would say to James, have you looked at you know, sort of opening your system up in some ways to you know, bring it to other countries or allow others to utilize your structure?
Yeah, so the data model is there and it's open, and it's something that we can enable others to make use of. We the company that I work with and we ultimately built the database with, they are a US based business, and we had used the data model to serve some smaller communities that were looking to roll out similar types of initiatives.
Great.
Perfect. And then just one last question to wrap this panel from Nathan Parker with OxyKit. How have you seen demand for oxygen supply itself shift over the pandemic, and how do you see the supply shortfall changing globally?
So I added a quick answer in there, and please feel free to follow up with me for further discussion. But there is a shift. There's clearly a shortage. There's been emphasis in looking at country capacity building, not only in terms of access, but production and distribution in country for oxygen. And so, I think it's still, we're still facing that next wave, and there'll be additional learnings from that. But that's been a lot of the focus. And Nathan, please feel free to follow up with me. Thanks.
Excellent. All right. Well, thank you everyone for speaking. I think we will go ahead and move into the next section.